Almost ready to go. I call to order the October, no it isn't. Let's start again. I call to order the Friday, November 17th meeting of Health and Human Services Oversight Committee. The clerk, will you please call the roll?
Representative Pearson.
Here.
Representative King here. Representative Gray. Representative Murphy.
Here.
Representative McDonald.
Here.
And by the way, I think I made a mistake. That should have been Senator Gray. Yeah, he's not here. Sorry about that. Representative Weber.
Here.
Representative Edwards. Representative Merchant.
Here.
Senator Rosenwald. Senator Avard. We have 6 accounted for.
And the others were gracious and let me know ahead of time that they would be absent. Next order of business is the minutes of Friday, October 27th. And we were sent these ahead of time, and we have a hard copy in front of us.
I move the minutes be accepted as written.
Second.
Any further discussion? Hearing none, the minutes are all in favor?
Aye.
Opposed? Minutes are accepted. Next item, before I forget, we are having a December meeting. And what we do when there is a holiday at the end of the month, we move, as we're doing today, the meeting up to the third Friday at 1 o'clock. So the next meeting will be December 15th, a Friday. Is it really?
I'm sorry, I'm in the wrong year. Never mind.
December 15th is a Friday. It will mostly be the Paula Minahan going away party that I hope will be extensively catered. But we may do some other business too.
Is there going to be an open bar for that?
Is Steve Ahern here to answer for that? Can we find out? Get back to us. 1 o'clock. Yeah, when it's on the third Friday, it's usually 1 o'clock because of a conflict some have in the morning. DHHS Commissioners Update. And the chair recognizes Commissioner Lori Weaver.
Good afternoon. That was fast. It usually takes a little longer to get through the meeting minutes. I thought I had more time. Thank you for having me. I have a little bit of I guess a variety of updates for you today, focusing on some things that maybe we haven't talked about in a little while, and one of those would be retention or vacancy rates. So I believe might have been beginning of this calendar year or maybe a year ago, I sat before you and talked about some of the challenges we had with recruiting. I am proud to let you know that we actually are improving our vacancy rate. About a year ago it was about 19.6%, and we're down to about 17.2%. So, that's, roughly we have about 2,700 positions filled, a little less than that when we were at about 2,500. So we'll always have constant attrition, especially with some of our direct care services, but we're making gains in the right direction. So we've gotten some new recruitment tools, software tools, working with the Division of Personnel, having really innovative ways to get out and get the word out of what type of jobs we have and what people would be eligible for. So we're going to keep marching in that direction. It's part of our roadmap for the department. We'll continue into next year and beyond of having workforce be a priority and be a goal. So that's good news. The other set of good news is that I recently nominated Marissa Henn to be Deputy Commissioner of the department, and it was confirmed by the council about 3 or 4 weeks ago. So Marissa Henn, who was an associate commissioner, is now the deputy commissioner of the department, and it's great to have a deputy. I haven't had one for a year, so happy about that. And we are actively recruiting to backfill for that associate commissioner position. So at that point, I'll hopefully have a full senior team to start the new year. And lastly, I just wanted to update you. We talk a lot about all of the things that are happening, and there's a lot in the department, as we know. Every single day there's something happening, but there's actually some construction happening on our campus, and it's been on time and is coming along. If you happen to work at New Hampshire Hospital, you are constantly reminded by the drills and the pounding that there is a forensic hospital going up right next to the hospital. So that has been a steady build, and they're on time as of this point in time, knock on wood.
When is the expected opening date or
I
hoped
believe
for?
it's the summer of '25. And then in addition, we have also been doing some renovations on what we call our E and F unit within the hospital, which is the 35 beds that have been offline for various reasons over the last couple of years. And that renovation will be complete probably towards the end of January, and we'll start to bring those beds back online, which will hopefully have an impact, at least for a point in time, on our ED boarding wait list. So we've been actively recruiting nurses. We still have the majority of nurses at New Hampshire Hospital are still agency nurses, but we are hiring full-time nurses as well. So we're making gains in that direction as well. So I think I promised to only bring good news today, and that is my good news list.
Any questions on the good news list? Representative Merchant.
Thank you, Mr. Chair, and thank you, Commissioner Weaver, for being here. In regards to the retention or the vacancy rate, rather, is there a certain subset that's more problematic than others?
Sure. Yeah, really, it's our direct care positions. It's our front facing, whether it's casework or whether it's actually doing direct care in one of our 24/7 facilities. Those tend to be the hardest to fill.
Thank you.
Anyone else? Thank you so much for your report.
Thank you.
Next item is update on protocol for complaints and investigations with the New Hampshire Board of Medicine. The chair recognizes Attorney Douglas Oosterhout. I'll do it in Dutch. And okay, here comes one. Jessica Kalopoulides, Greek?
It is Greek. That was very close.
Polides?
It's Kalopoulides, but that was
Leet.
That was
It's
great.
a long, okay, got it. I was debating between Koine Greek and Classical Greek, and I lost. Thank you for coming.
well. Our name was changed when my great grandfather came to Ellis Island. He was speaking Greek, and that's what they wrote down. So that became our last name, and that's how we.
He was very blessed that it just didn't become Cali.
Yeah.
Anyway, yeah.
Hey. Okay. So good afternoon. I appreciate the time. I did send a handout. I don't know if everyone has it. I just want to make sure. No. It was sent electronically, but I do have hard copies as well. Just gonna. So I'll wait till everyone has it to go into detail, but this doesn't include every detail in the complaint process, but I think it's a good sort of overview and a good place to kind of start the discussion. Oh, I have more here. All right, so what you have before you is basically a flow chart illustrating the post HB 655 and HB 409 enforcement process, not only for Board of Medicine, but other boards as well. And this is for non-emergency matters. So if a complaint, if alleges something that would be an emergency, there's a different process we can talk about if you'd like to, but this is a non-emergency process. So a complaint is received by the Division of Enforcement at OPLC, and it is reviewed for It's a legal review to determine, is it facially valid? Essentially, assuming all allegations are true, does it allege anything that would be misconduct or unprofessional conduct? So we review that. If the determination is that it does not meet that standard, then we draft a recommendation for dismissal, and that goes to the board. So only the board can dismiss complaints. We can only make a recommendation. We being enforcement, so right now, all the attorneys in enforcement review complaints. We take turns. We are hiring an individual to specifically do that.
Attorneys of enforcement at OPLC.
Correct.
Thank you.
So again, we can only make a recommendation. We can't actually dismiss anything in enforcement. It's up to the board. So we send the recommendations for dismissal to the board, and they can dismiss. Or they can look at it and say, no enforcement, we don't agree with you, and they can send it back to us. If that happens, we'll request a response. If we look at a complaint and say, yes, this is facially valid, then we would request a response. So those are the two ways that we get to the response phase. Once a response from the licensee is received, the complaint and response are reviewed again. Sometimes the response provides enough information, particularly in like medicine cases where they might provide some documentation, some records to help support their position. That might be enough. We may recommend dismissal again at that point. We're able to do that. So that is not depicted here just because there'd be too many arrows. It would get really messy and confusing. But we do another review at that stage to determine should it be dismissed or should it be investigated. So again, we would send any recommendations for dismissal to the board. That's purely their decision. They can either agree and dismiss or send it back to us and say, we don't agree with you, enforcement, go forth and investigate. So if the board sends it back or we review and say, yes, this needs to be investigated, it is immediately assigned to an investigator who begins an investigation. Once they complete their investigation, they draft an ROI or report of investigation, and that is sent to the board with a recommendation. The recommendation may be to dismiss at that point, or it may be for adjudication. Again, that's a recommendation. The board gets the ROI, and they make a decision. They can accept whatever the recommendation is, or they can make a different determination. But the board at that point, upon receiving the ROI, would either dismiss the case or order adjudication, and a hearing would be scheduled.
Any questions on the diagram, Representative Merchant?
Thank you, Mr. Chair, and thank you for taking the question. On the process where I saw the complaint review, what I think I heard was that's done by attorneys, not done by peers. So therefore, I don't know whether the attorney has the clinical knowledge to make a determination from whether it's clinically relevant versus just legally relevant. So how does the clinical team get pulled into that review process?
Yes, thank you for the question. So it depends on what the complaint is, right? If it says my doctor sexually assaulted me, you don't need a clinician to tell you that that's facially valid and needs to be investigated. If you get a complaint like this is a real complaint from Board of Nursing, the nurse gave me the wrong color Jell-O, you don't need to be a clinician to know that that's that's not facially valid. For the ones that you do need that expertise, we would rely upon our contractor who we work with, who is a physician, to help us make that determination because we're not doctors. So it depends on what the complaint alleges. Sometimes we can tell from what it says, and if we can't, if it has medical language and it talks about standard of care, I'm not going to know that. I'm not a doctor. So we're going to rely upon someone who is to assist us in making that recommendation or determining that it should move forward.
Representative McDonald.
Thank you, Mr. Chairman. How many complaints do you have pending right now?
That is a really great question. For Board of Medicine specifically, or all boards?
All boards that are affected by this.
So this is the process. It's a lot. I don't have a specific number. We have had a number of challenges regarding the electronic system that we keep track of cases in, and a lot of improvements have been made recently that allows us to better track them and close out the ones that need to be. And we are working on getting a new system that will allow me to just provide that information. But right now, I don't have a lot of confidence in the data, and so I'd be hesitant to give you a number. What I can tell you is that through this new process, recently there was a month where the Board of Medicine was able to dismiss over 100 cases because we've made a push. Board of Medicine does have a lot of pending cases, so we've made a push to review as many as we can. And to be completely transparent, a lot of those were sort of grouped in the same bucket, so it was easy to make a recommendation for a group of them. But we were able to do that for over 100 complaints in 1 month, which means that those are, and they agreed and they dismissed them. So that means that those are taken off the case list and we can focus on the ones that do need to be investigated.
Follow up?
Follow up.
When you say dismissed, does that mean unfounded, basically?
Right, it's
Lack of
facial,
evidence, whatever?
right, it doesn't rise to the level, it doesn't, right, the board decided to dismiss it. I think our recommendation would be it's facially invalid. It doesn't rise to the level of professional misconduct. And I assume they agreed with that because they dismissed it, but they did dismiss it.
Did I have one more?
One more.
Thank you, Mr. Chairman. What's the, and I know it would vary by department and severity and so forth, but what's the average turnaround time on a complaint and the investigation and so forth, resolution?
So it does vary a lot depending on board, also complexity of complaint. Some medicine cases, especially if there's multiple doctors involved, may take much longer. If it's something that maybe is not emergent, but is urgent, let's say, it's going to be prioritized, so that would be moved much more quickly. So it depends. I can tell you what our goal is moving forward as we're sort of cleaning this up. And like I said, trying to clean out the cases that should be dismissed and investigating the ones that warrant investigation. The goal is any complaint, the maximum amount of time from time of complaint receipt to, assuming it goes to adjudication, because not all do, but assuming it does, to decision is 1 year or less. Most of them should probably be much less. So a lot of them will be dismissed at the complaint or complaint and response phase. Some of them, the investigation may take longer or shorter. If there's a hearing, obviously that time frame is a little bit longer than if the board dismisses after an ROI. But the goal is every complaint that comes in, the maximum amount of time it would be around is 1 year, and that's assuming that it does go to hearing. Okay. There would be a rare exception for certain cases, either really, really complex, which we usually don't see in administrative law, but we can. Or if there's a criminal component, sometimes just because the criminal portion of the criminal courts may take longer. So sometimes, depending on how we need to handle things, it might take a little bit longer for our case, depending on what's happening in the criminal court.
Thank you.
Representative Murphy.
Thank you, Mr. Chairman, and thank you for this flow chart. It is actually very helpful for me. So according to the flow chart, unless you have a need to have a clinician present or to evaluate, the Board of Medicine will not see this until an ROI is made. Is that correct?
Right. If we don't recommend dismissal, then yes.
But that's the first time they'll see it.
That is the first time they'll see it.
So at the very beginning, the complaint is received. I'm assuming that means also like a malpractice lawsuit. Is that correct?
Yes.
And how does that report come to you, that complaint come to you? Does it come with 5 bounds of charts from a hospital? Does it come with an executive summary? How do you get that report, say, specifically of a malpractice suit?
The malpractice suit typically comes from the court because they're supposed to notify us anytime when it's filed. There's a cover letter saying we're disclosing this to you, and then it's a copy of the complaint filed in civil court, and that's typically it.
Just one more follow-up.
Follow up.
And you mentioned the complaint reviewed by a contractor. Is this what is a contractor? Is it employed by OPLC, or do you pull people in regularly depending on the case, or what is a contractor and where do they come from?
Sure. So we contract with a physician he's an investigator who works with our office. We have a number of contract investigators with different expertise. So Board of Medicine currently has one, and we're working on additional contracts for additional people with different areas of expertise. But Board of Nursing, Psychiatry, the veterinarians, a number of other boards utilize contract investigators to help us where we need that expertise, because our investigators are experts in investigating, but not necessarily in
Subject
matter,
yeah.
right, subject matter in medicine or nursing or those types of things. So, so we work in conjunction with them. So when I referred to the contractor, it's the physician that we currently contract with.
Okay.
Like I said, we're working on getting other contracts into place. We used to have the medical review subcommittee, and there were some challenges with that. But when we lost that group, we did recognize that we needed additional contracts in order to continue this work.
I'm sorry, just one more follow-up.
One more.
When we were looking earlier in the year at the Board of Medicine in the committee or commission or committee to evaluate the Board of Medicine, one of the big issues that came up was staffing or the lack of it. Do you feel like OPLC is staffed adequately enough to handle the number of cases that come before you?
Currently, I do. We did just add, I think it's 1.5 investigators. We had one part-time investigator who left, and we replaced that person's position with a full-time, and then we hired an additional investigator. So right now, I feel we are fully staffed to handle what matters we have. And like I said, that goal is to have that 1 year or less time frame. And as we move along and get better data, we'll be able to identify whether we truly are fully staffed rather than feeling like we're fully staffed. So,
Thank you.
yep.
Representative Merchant.
Thank you, Ms. Chair. Thank you for taking the question. I also, like Representative Murphy said, I found this to be very interesting. I think one of the comments I heard about this, it does not only apply to the Board of Medicine, but to other entities within OPLC. So in saying that, is the process going to be the same for other healthcare providers, whether it be a podiatrist, chiropractor, a dentist, and so forth?
Yes, HB 655 and HB 409 essentially consolidated the process into one process, whereas before we had 50 some odd processes because every board wanted things slightly different. So now we have one process.
Follow
Follow-up.
Thank you. Can you speak to the communication process between the time a complaint is filed to the time there's resolution to it? How is the person who's been the individual who filed the complaint, how are they kept in the loop that something's actually happening? If it goes out for a year and there's no communication with the person who's filed the complaint, it's going to sound like it may be falling on deaf ears. That's one of the questions. The other question is going to be is how did the person who wants to file a complaint, where do they go and how do they know where to go to file the complaint? Because if the system is problematic, so it's two questions, I guess. One is, what's the communication process with the person making the complaint? And what's the communication to the people out in the public that they know where to go to file a complaint?
Sure. I'll answer the second one first, if that's okay, because I think it's an easier, shorter answer. We have a complaint. I mean, people can file complaints however they're comfortable. So if we get some by snail mail with hard copy, sometimes they just email us. We do have the information on our website, how to file a complaint. We have an online form that they can complete and send to us. Not everyone's comfortable doing that. So like I said, if they want to email us or if some people write out or handwrite us something and drop it in the mail, we'll take it through all those means. When we get a complaint, they get a receipt of acknowledgement. So we have received your complaint. If it does go to, if it's recommended for dismissal and it's dismissed early on, they're going to get a letter from the board indicating your complaint was dismissed. If it goes into investigation, then an investigator would reach out because that's part of the investigation. You don't just take, obviously, what's in the complaint. You want to talk to the complainant and get some additional information. They may have to be a witness in a hearing, so we want to talk to them. So they would know the investigator who's working on their complaint, and they would know it was in process. So they'd have a avenue to communicate with our office regarding the status if it's an investigation. Now, what we can tell them is very limited because even though they are the complainant, investigations are confidential. So they know it's been filed, they know it's being investigated because they're part of the process, but we're very limited in what we can tell them until there's really an outcome.
Representative Weber.
Thank you for taking my question. Thank you for being here today, and thank you for the updates.
I notice that if I go to the Board of Medicine page, I can't find the complaint procedure unless I happen to click on frequently asked questions. And I wonder if it might be helpful for the public to have a link on that front page. If I go, for example, to the Attorney General's office and I have a complaint about something, there's something right on their front page that tells me how to get there. So I wonder if that might be helpful going forward.
Okay, I appreciate that feedback. It should say report or file a complaint at the top of the page, and I thought that there was a link further down the page, but I appreciate that feedback, and I'll certainly look into it, and I'll bring that back.
No, I'm wrong. I am mistaken. There is a file a complaint thing. It's in the line with the other stuff. So I was reading down.
Okay,
So,
still valuable feedback though, because if you weren't able to find it when you went there looking for it, others may not as well, so thank you.
I'm old and big type is really helpful.
Representative McDonald.
Thank you, Mr. Chairman. I used to be an investigator with the department and the fraud unit, the welfare fraud unit. That's why I find this very interesting. And I know on an ongoing investigation, you're very limited in terms of what you can share. In fact, we couldn't share anything. We'd take the complaint and then we'd proceed. And unless it went to court, we couldn't share anything. If it was an administrative hearing, we couldn't share anything. How much are you able to share? When you said you can share the outcome, are you able to share the outcome?
Enforcement is not, the board is, because that's a board decision. So that's
Okay.
communicated through the board administrator. So that is communicated to both the complainant and if it, if it goes to investigation, then obviously the licensee needs to be notified as well of the outcome.
But it doesn't have to go to court for the outcome to be known.
It does not have to go to court, right? The hearing is before the board. And then the
And
board
that's
would.
public or?
Yes,
Yeah,
the hearings are public.
Okay.
I think we've had very rare occasion where maybe the subject matter being covered was very sensitive, so it's been sealed, or portions of it have been sealed, but they are generally public, yes.
Okay, thank you.
You will recall a while ago, the Boston Globe investigated the matters of a surgeon at CMC, and that the Massachusetts Board of Medicine reported 20 settlements, and the New Hampshire Board of Medicine reported none. And that led to thorough, multiple pages of report in the Boston Globe. I was interviewed extensively by the Globe. I was in media, so, and then by other media outlets. And lately, they've been giving me a call and saying, how's it going now compared? And I wanted to wait until I heard from you folks before I get back to them. And would now the New Hampshire Board of Medicine have this information report this information, whereas before they didn't?
I'm sorry, I'm not certain I understand your question.
The public did not know.
Yeah.
By the New Hampshire Board's revelations about the 20 malpractice settlements of the surgeon, unless they read the Massachusetts Board of Medicine's website. And we were told at the time, well, the procedures, the staffing, this, it sounded plausible. I didn't think anyone was being bad. I just thought we need to be updated. We need to change procedures. We need to hire a few folks. Would you say that the legislation, now law, and the efforts at OPLC have improved to the point where that problem will no longer happen?
So I think with the improvements that we've had, so if a case, like I said, cases are confidential basically until there's a hearing, right? So the hearings are public, so that would be available, that would be noticed, that would be public. Any outcome, if there's a settlement agreement, if they settle prior to a hearing, but adjudication's been ordered and they settle, or even if it's before then, if there's a settlement agreement, if there's a finding of misconduct, whatever the board orders are, those are all on our website. And those are also, if you look up a licensee, they are also posted there. So if you have a new doctor and you want to look them up, you can look up their license, make sure they're actively licensed, and see if there's any discipline attached to their record. I'm not certain if that's answering your question.
I'm not sure I'm asking it exactly to get the information I wanted, because maybe the 20 things that were reported in Massachusetts hadn't been settled or were settled out of court or whatever they were. It wasn't up to the standard of what the Board of Medicine was allowed to do, could do, or whatever. Counselor?
Good afternoon, Douglas Osterhout,
afternoon.
PLC. I would say that a majority of the changes that we saw in 655 and 409 updated the process, not so much the information we're allowed to share.
Mr. Chair.
Representative Weber?
I think I can maybe help out.
Thank you.
Is it not true that we had a number of meetings where we tried in various fora to describe what things must be posted, and to date, we haven't actually reached a consensus about what things must be posted, so that the actual postings are not that different from what they were before. What is different from what they were before is a more robust investigative process.
I would say that's accurate.
Thank you.
This is for anybody, is the process of coming to arguably better postings are still a work in progress?
Well, can I ask a question? When you say that there were settlements and you kind of referred to court settlements, I mean, those will never be posted on our website if it's a court settlement. If we receive such a document and it's considered a complaint, we're not going to post that because it's confidential. The courts, it's difficult to find out, I mean, I moved here from another state. I used to look up and do a civil case search to see any of my new doctors, do they have any medical malpractice cases that were filed against them? And I could see all the pleadings online. And I found that New Hampshire has chosen not to do that, which I'm not making a judgment call, but that's not something you can just do. But case filings would be something the court would have to post. We would not post those.
Follow-up, Representative Weber.
And this is just a statement. My recollection is that we had a number of discussions, I think, in the context of a bill. And the issue that we wrestled with, that I think everybody wrestles with, is where is the line between information that is clear that needs to be shared with the public, and how early in the process do we make things public in order to be fair not only to the public's right to know about their providers, but also whether the complaint is about the color of the Jell-O rather than, which may be a valid complaint, but it's not actionable in terms of somebody's practice. And my recollection was that we wrestled mightily and didn't have a lot of success in deciding where that dividing line ought to be. So I think probably the legislature needs to take some ownership for the fact that until they do successfully grapple with that issue and set a very clear standard for what's going to get posted isn't going to change unless it somehow gets changed by rule. But I don't think we've delegated that authority, so it can't be changed by rule. So until we do something, I don't think anything's going to happen, if that's a help with the process. If not, the answer.
Well, I think it is, because the answer seems to me that the difference between what the Massachusetts Board of Medicine felt comfortable in posting versus the New Hampshire, leaving any legal terms out of it, whatever they did, we didn't. And that isn't changing yet. Okay. That's very helpful. And thank you, Representative. Representative Murphy.
Thank you. Just to follow up to that conversation. So is it fair to say on your flow diagram here that if a complaint were to result in any sort of reprimand, that would not be released to the public until it got to an ROI into the Board of Medicine? it would not come out publicly before that. Is that correct? So if a complaint comes in to the to the OPLC, and you've gone through your entire process of reviewing, an investigator is assigned to it, et cetera, and a judge or a ROI is determined or is given, it would seem to me then that part would not be public. Is that correct? That would not be publicly available in most other states as well as ours, but it could be at the point when it gets to the Board of Medicine.
It's accurate that the ROI, it's not public at that point because the board hasn't made a decision, so, right.
But it's when the Board of Medicine gets it and they make a decision to dismiss or adjudicate, that's when it would be potentially out on the public domain. Is that correct?
Right, if they order adjudication, the notice of the hearing and the hearing would be public. If it's dismissed, then there's no notice to the public that a complaint had been pending.
So nothing up to that point in time of the ROI, I guess what I'm asking is, nothing up to the point of the ROI is really available to the public.
Correct.
Okay, good, thank you.
It would be, just to beat it to death, it would be the legislature that will inform OPLC or the boards. That's one question, where the line should be. You aren't going to do that.
They can't change it without authorization.
That's what I'm trying to pound several nails into.
Correct. Right now, we are unable to disclose that information.
Okay.
Right, it would have to, I believe, have to be a statutory change to allow that.
Mr. Chair,
Yes.
if I could, I think this transcends the Board of Medicine. I think if we're going to do it for one healthcare discipline, we have to be doing it for all, not just for one, and single someone out.
Sure. Anyone else? Thank you, Attorney Oosterhout. And Ms. or counsel or what? Doctor? I'm buying time until I keep rehearsing. It's
Yeah. Don't worry about
I
it.
as an E.
I mean, I am an attorney, but Ms. is fine as well.
Counselor Kalapolitis.
Perfect.
Thank you for
Thank
coming.
you.
One more update. Last legislative season, the Board of Medicine, with the MRSC going away, was given statutory authority to create a subcommittee, and they can create essentially a panel of experts to aid our investigators during investigations. That's currently in the rulemaking process. There's drafts. I don't have anything yet to share, but the Board of Medicine is working on those. So in the future, this extra panel to assist our investigators will exist.
Good. Thank you.
Of course.
Next item, the Developmental Services Redesign Implementation Status Update. Pinch hitting for Melissa Hardy is,
And just so you know, Mr. is perfectly appropriate for this.
I understand that. I understand that.
Good afternoon, Chris Santinello. I'm here for Melissa Hardy today. So I actually probably have a relatively brief update. I know that Melissa, typically this was regarding Retain 608, which is now interim study 608, correct? Recommended, thank you.
The House has to vote on it in January.
Okay, so that's kind of where we are. November 3rd, we presented to the subcommittee on HB 608. So some of this information may be repetitive. I know Melissa spends a lot of time here talking about stakeholder engagement, and I think that's where I'd like to spend our time today, if that's okay. When we met in front of the subcommittee to hear Retain 608, I shared and I reiterate today that the department is committed to collaborating with all stakeholders to improve our developmental services system. I think there has been a lot of anxiety in the system because We had a number of items that we had to move forward for compliance, and now we're past that pit phase. And so we really have the ability to stop, pause, and get meaningful engagement from all stakeholders, whether that's an individual, a family, provider agencies, area agencies, whomever. And so we've actually started to map out some of those stakeholder engagement sessions. And starting in, I think it's after Thanksgiving, we're going to kick off a number of 4 family and information settings, just to really talk and understand what's working well, what's not working, what do you want to see changed, and begin to go down that process. So that's really kind of where we are right now. And then we will also be meeting with the area agencies through CS&I to ask some of the same issues, and then also with our private provider networks. And we're spending the time really, we don't have any firm start dates for any new changes to the service delivery system. We've put some of the rate work on hold, not the HB2 rate work. That's still happening January 1st, but some of the other rate work, we're putting that on pause a little bit, so.
Any questions from the committee?
Mr. Chair.
Yes.
Thank you,
Merchant.
Mr. Chair. Also, thank you for the update.
Yeah.
One of the things also they talked about was the process, which I'm glad to hear that we're bringing back the stakeholder involvement
Yeah.
to this degree. I think it's helpful for both sides of the fence. Was the cash flow issue? Was trying to find a way to be sure that they're staying financially viable. And a lot of that comes down to is trying to be sure that they're getting sufficient cash because of the issues around the billing issue
Yeah.
and so forth. Can you speak to where we are with that part of it? Because
Sure.
it's nice to have a process, but if
Yeah.
you don't have agencies to do the process, we don't have to worry about.
Yep, totally agree. So we actually have been meeting with area agencies one-on-one, because I really think that, you know, yes, we do lots of training and information and meet with a group, but meeting with agencies one-on-one to really understand what's your pain point, what do you need help with? And so we've had at least 4 of those with 5 individual meetings. One was around service authorization, the rest was around cash flow. So we're continuing to work with them, and if we have to give manual payments, we've been continuing to do that. We have, I know when we were at the subcommittee on the 3rd, we talked about slowing down like that December payback, and we've absolutely done that. Really on an individual basis. Really, it's up to the agencies, but we meet with them upon request immediately.
Thank you.
You're welcome.
Representative Weber.
And I'll just note, for having had a conversation with somebody from an agency fairly recently, there is still considerable anxiety out there about the payback issue. So that needs to be communicated more
Yep,
clearly.
I totally agree.
And not necessarily to me. And the other piece that is causing a great deal of heartburn, other than the how do we enter things properly into the system so that we can actually get reimbursed, and the mess that was, which is slowly, I think, being unraveled, is the issue of direct entry for the services, and the whole issue of how do we do it when the cell phones don't work and that kind of thing.
Correct, yep.
So ongoing angst is out there, but
I understand.
I know everybody's aware of it.
And we're actually really, I think, at a point and working together on, okay, what's the issue? How do we resolve it? How do we work together? What are our next steps?
Okay. Thank you. I just want to make sure people hear it as often as possible.
We hear it. Thank you. And I
Any other
appreciate you
questions?
bringing that forward.
Any other questions for the Associate Commissioner? Seeing none, thank you for your report.
Thank you.
Next up, report on veterans' access to health care and mental health services. And we welcome Wendy Altman and Heather Smith. And the streak continues of the ability to turn the mic on at the beginning without coaching. Well done.
Getting the hang of it. For the record, I'm Wendy Altman. I'm the Bureau Chief for the Bureau of Elderly and Adult Services.
Good afternoon. I'm Heather Smith, and I work at the Department of Military Affairs and Veterans Services, Division of Community-Based Military Programs as their Grants and Resource Development Coordinator. Thank you.
So today we're here in front of the committee to be able to offer some highlights and information related to Senate Bill 174, which is relative to veterans' access to healthcare and mental health services. We've provided a report based on the legislation that was passed this past year, and both Heather and myself as partners are prepared to be able to just provide some of those highlights and talk about some of those initiatives, and then offer the opportunity to answer any questions that the committee may have. First, I'd like to just review what we've provided in the report. Again, we've listed out many of the initiatives that include collaborations and partnerships between the Department of Health and Human Services and the Division of Military Affairs and Veterans Services. And in addition to this report, we are providing a snapshot from 2023 that was released that provides an overview of New Hampshire veterans in the state, which covers some demographic and economic information, as well as some programmatic information highlighting how we are supporting New Hampshire veterans in our and how we partner in different ways. And so we're happy to answer any questions relative to that. As part of the Department of Health and Human Services role, we continue to have dedicated staff within our community mental health centers contracts that focus on military services and help those who go to the community mental health centers with supports and have that subject matter expertise. We also partner very closely on training and outreach and as it relates to military culture. We've just had some recent meetings about scheduling out some of those trainings that we will offer statewide to all of our human services partners. We also work very closely with our Aging and Disability Resource Centers, also known as Service Link. We partner with both of the VAs, the White River Junction VA and the Manchester VA, to ensure support and options counseling for veterans who want to receive and direct their own care in the community, which are services that are funded through the VA with service-connected veterans. And we provide warm handoffs or, close partnerships with the Office of Veteran Services in terms of helping individuals who may need help with long-term supports and services and navigating supports in the community, but also need help with questions related to VA benefits or navigating peer support, mental health services, and making referrals to the Veteran Services Office. So I'll turn it over to Heather so that she has a little bit of time to highlight things from her division's perspective.
Thank you, Councilman Pearson, our Chairman Pearson and all the honorable committee members for allowing us to testify today as to Senate Bill 174. We're happy to share all the initiatives that the Department of Military Affairs and Veteran Services and the Department of Health and Human Services are in collaboration with and in tandem working towards helping veterans access healthcare and behavioral health services. So I'd like to highlight some of those initiatives. At this, our department, the Department of Military Affairs and Veteran Services, we support and participate in various state councils and committees and meetings to support families and veterans and their families in the state. And that includes the New Hampshire State Military Leadership Team and the State Veterans Advisory Committee. And so I wanted to give you a little bit of background as far as the New Hampshire Military Leadership Team was the beginning genesis for our initiative of the New Hampshire Veteran Friendly Business Network. And that Veteran Friendly Business Network started with that military leadership team and the State Veterans Advisory Committee coming together with our partner in New Hampshire Employment Security. And we partnered with area businesses such as Next Step Bionics and Prosthetics, Dead River Company, Hypertherm, New Hampshire Hospital Association, Northeast Passage, UNH, Southern New Hampshire University, and an ESGR, which is Employer Support for the Guard and Reserves. And so now this network is in its 4th year, and it is still growing. We have 60 plus businesses, and we had a recent symposium in which 40 of the businesses participated. In addition, the military leadership team and the State Veterans Advisory Committee is providing shaping guidance for reinvigorating the New Hampshire Ask the Question campaign, which if you're all most likely familiar with, is whereby a clinician, care provider, law enforcement teacher asks if a family member or yourself has served in the military. And so that enables a provider to address the next level of care in a more targeted approach to veterans' health care. And then another initiative that the military leadership team and SVAC is assessing is addressing the gap in dental health care needs for our veterans. We are modeling our approach after the state of Maine, and worked in coordination with Northeast Delta Dental to provide coverage for veterans that cannot pay out of pocket or do not have access to dental insurance. So in addition, there are available services for veterans in isolated pockets of New Hampshire, such as in the North Country, that will provide on a regional level assistance. We do not have a statewide program for that. So we're currently looking into this through and assessing the capacity and resources that are available to meet these needs at this time. In addition, I'd like to highlight some of our the outreach that our veteran service officers, the Division of Veteran Services. As you see on our page here, we have over 94,000 veterans in the state of New Hampshire. Only approximately, I would say, 40% are enrolled in VA healthcare system. But so we have a small office of veteran service officers that work with these clients, bringing in approximately $65 million each year of federal funds into the Granite State to assist these veterans. The Veteran Service Officers caseload, they have approximately 4,000 contacts via voice and email. This rose during the PACT Act period up to 6,000 a month. And now that PACT Act enrollment period has passed, we're now back down to approximately 4,000 a month. And right now we are currently booking appointments for services into December and January. We also work in partnership with DHHS, the New Hampshire National Guard, the New Hampshire Suicide Prevention Council, and other state departments and community providers to prevent suicide amongst veterans. We also participate in the Suicide Prevention Council Military and Veteran Committee. Through these recent efforts, we are able to work with DHHS along to highlight the Governor's Suicide Prevention Week. You saw the impact of that in the recent press releases, as well as the Granite Strong campaign, Strong as Granite. I do want to let you know that the U.S., the U.S. Department of Veterans Affairs released data yesterday in regards to New Hampshire veteran suicide. This rate has dropped. It was 36% in 2020 and is now 29.3% in 2021. While we recognize that this is great news that the rate has dropped, we still recognize that the veteran suicide rate is still higher than the national suicide rate average and the state of New Hampshire average. Let's see. We also like to highlight there's some available suicide prevention training. Through the New Hampshire National Guard, there's a Assist Applied Suicide Intervention Skills Training. It's a 2-day training. And NAMI New Hampshire designs and teaches the Connect Online training. It is a 3-module self-paced and can be taken online. In addition to that, NAMI New Hampshire worked with Harbor Care to provide train-the-trainer training for suicide prevention. And through those efforts, we're now able to continue outreach to the VFW leadership. They're collaborating with the VFW leadership so that the VFW post would have a point of contact if somebody had suicidal ideations. So reaching out to those communities on a broader effort. In addition, the Department of Military Affairs and Veterans Services has contracting efforts with Easter Seals New Hampshire to provide, to have enhanced capacity for mental health services, and to New Hampshire service members, veterans and their families, as well as contracting efforts with the Partnership for Public Health to create coalitions to address veteran suicide and social isolation.
I'm going to ask you to kind of bring this to a conclusion. I'm following along this and I intend on reading it at home, but perhaps the committee would wish to ask some questions.
Oh, I certainly, I apologize.
No problem.
Yeah.
Representative Merchant.
Thank you, Mr. Chair, and thank you for taking the question. The intent of the bill was to look at healthcare, mental health access by the veterans. In your opinion, in writing this report, would you say it's a lack of awareness? Is it a question about availability of workforce? Is it a question about locality? In other words, in the state of New Hampshire, we have one VA facility in Manchester. We have another one on the border with Vermont, White River Junction. Is a question of awareness. We don't have enough people to provide service to the veterans, or they just don't have time or the ability to get to the sites where they can get the service.
So just to understand your question, you wish to know if there's a lack of capacity to.
Is it a lack of the veterans being aware of what's going on and what's available to them? Is it a question of lack of capacity, which is really driven by the workforce? Or is it a lack of access in a sense of geographically? If I live in Burlington, Vermont, if I Burlington, New Hampshire, and I have to go all the way down to Manchester, it becomes a difficult journey for me to get down there.
In terms of the needs, part of the snapshot that was provided in the packet really does outline a couple of the needs that we focus on. One of those is the coordinated referral and assistance, which really is we need to make sure that veteran service members and their families have increased awareness. So, that definitely is part of the initiatives and efforts. It's weaved in everywhere. The other is increasing the capacity for community-based services and having that equitable across all regions. So that's certainly something that we're looking at when we do our listening sessions or gaps analysis in terms of what may be available to individuals and veterans. Military service members and their families are part of that population that we're working with, and certainly with the veteran service officers, the goal primarily is to make sure more people have increased access to the VA enrollment and what that process looks like, and being able to support them through that.
Thank you.
Representative Weber.
This is mostly going to be observations and some of it's a plea. If I were a veteran, I wouldn't know whether I needed to go, because I'm in Cheshire County, to the Keene Veteran Center, to the White River Junction VA Center, to the Manchester VA Center, or would I call the Community Behavioral Health Center, or would I contact NAMI, or would I try and get through to 211, which is sometimes not as helpful as it might be. And so I'm going to do the thing that I've done in the context of any number of other agencies and say, I have 20 years of formal education and a law degree, and I'm a representative, and I have access to a lot of people to explain things to me, and I have a good computer, and I can't figure this out. So if I don't have good access to computer services and people who can help explain it to me, what I've heard today is who is liaison with who and partnering with who and making a web with who. And I wind up with an image in my mind of a giant spider web where everybody's talking to everybody else about who's talking to whom. And I'm still not clear who's providing the services or where. And I know that in the context of mental health access for the general population, we talk about no wrong door and we talk about getting people to the services they need. But dear God, could we have fewer doors and, a simpler and more direct line to services overall? I know that's not something you're going to do by next Friday, but it's a plea that I make because I sometimes try and explain to constituents where they find services. And when it's hard for me, and I've been serving on Health and Human Services for 6 or 8 years now, if I can't find where they should go, then how are they going to find it? I mean, I always do, but that's usually because I call our Mr. Williams and he points me in the right direction. And not everybody can do that. And he can't do that for everybody in the state. So I'm really concerned about the number of different organizations that each have a little tiny piece of the pie. But I'm afraid that there are an awful lot of veterans who are getting no pie. So I just throw that out there because it's a real concern to me. And I'm sure it's a real concern to you as well, because I know that you're working hard on it, but it's not easy.
Thank you.
Chair has a question. Speaking of Mr. Williams, he regularly plies us with a document called DHHS Contact List for Constituent Referrals. And I'm looking down on page 2 to elderly, long-term supports and services, indent, elderly and adult services, skip a line, Wendy Altman Administrator. But the line I skipped talks about community services, nursing home and residential care. I don't see veterans on there, should I?
We wouldn't necessarily specifically identify one population. We serve all populations, all payers. So in terms of whether or not somebody's served in the military or they have family who served in the military, that's something that we would ask based on them, contacting us and providing, a warm handoff to an organization or one of our program staff within the bureau if they had a specific question or need that may relate to their connection to being a veteran or a service member.
Allow me to disagree. The line item speaks specifically of nursing homes. And then we get down a little bit further and we talk about seniors with mental health needs. I'm reading this document and I'm seeing some nice breakouts. This doesn't help me in terms of what Representative Weber isn't feeling helped with. This document. I appreciate it. It's better than none. When I was growing up, I never had anything like this. This is wonderful. It's not enough. If you want to make it 4 pages, fine. But I want to be able to see under the subheadings and the sub-subheadings a lot more breakouts as to whom I call. And not just on your line item, which I don't think you probably wrote. I think somebody wrote it for you. And some of the others. This is a good start. It's not enough. That's my plea.
Thank you. And I'll pass that on to John Williams.
He's on vacation in North Carolina visiting. He told me Mayberry and Andy and Goober and Gomer and Barney Fife. He said that actually in a memo. But when he gets back, yes, this will be very helpful in the next edition. Thank you. Anyone else?
Chairman.
Yes, Representative McDonald.
Thank you, Mr. Chairman. Let's hope Andy doesn't arrest Mr. Williams while he's
That
down
would be
here.
Barney anyway, but
I'd always heard, and I don't think it's in here, and I don't think you've addressed it. New Hampshire has, if not the highest per capita population of veterans, we have one of the highest. Is that true?
I believe we are in the top 10, sir.
Okay, top 10. Okay, so we're not the most per capita then, because I had heard that. But it's a fairly heavy per capita veterans population from what I can see. Is that fair to say, or?
Are you looking?
I know it's not broken out like that. I'm just thinking that contributes to the problem that it's that heavy. So, anyway, thank you.
anyone else? Any other questions? Thank you so much for coming.
Thank you for your time.
And report update regarding the use of restraints and the use of different modes of transportation of patients to New Hampshire Hospital or designated receiving facilities. And this is of particular interest to mine because my other son, not the one that's in the legislature, he's on Team Red, he's a fire lieutenant, but my younger son, Michael, who's Team Blue, who's a corrections officer at a maximum security prison in New York, and he transports patients back and forth all the time. So we've had long chats on this. So this is going to be fascinating to me. I'll try to show restraints in my enthusiasm.
Just for clarification, when we talked about Team Red and Team Blue, was that fire and police?
Yes,
Thank you.
welcome. They have a hockey game every year.
Well, good afternoon, Mr. Chairman, members of the committee. Thank you for having me. My name is Caroline Lavoie. I'm the Senior Director of Health Information and Analytics at the New Hampshire Hospital Association. And
I am Cynthia Babonis, and I'm here representing the New Hampshire Hospital Executive Team.
And I'm going to walk you through the fourth iteration of this report. But before I do so, I do want to give just a little bit of background on why we are collecting and reporting on this data to you. So all patients designated as an involuntary emergency admission, or IEA, in New Hampshire must be transported from the emergency department from which they were admitted to New Hampshire Hospital or another one of the 6 designated receiving facilities, or DRFs, to receive the appropriate inpatient psychiatric treatment. Historically, those transports were all done by law enforcement, but Senate Bill 177, effective January 1st of 2020, allowed for the explicit option to use an ambulance for the transport, along with law enforcement. And the idea was to reduce the number of restraints and associated trauma, but still protecting everyone involved, the patient, the employees, and the general public. So now, a provider who declares the IEA chooses the appropriate mode of transportation for the patient, and the transport agency themselves decides if restraints are appropriate in the situation. In addition to these changes in protocol, the law also mandated that all the DRFs report annually to this committee on the number of restraints broken down by age, type of transport, and restraint usage. New Hampshire Hospital Association volunteered on behalf of its members to consolidate this and bring it to the committee in a consistent manner. So this is now the fourth report that is brought to the committee, and it's covering the months of October 2022 to September of 2023. And if we turn to the report itself, so the top of page 1 just has a little bit more background on Senate Bill 177. And the bottom of page 1, there's some summary statistics for you. So there were 1,146 IEA transfers in this year. That's an average of 96 per month. 99% of those transports were adults. In terms of type of transport, we had 38% by ambulance, 61% by law enforcement, and 1% by other means. And other means could be facility staff, family members, that type of thing. Just over half of all transports did use restraints to move the patient. And in terms of type of restraints used, I have the breakdown there. Just about half were a combination. And then there are others, handcuffs, waist belt only, leg restraint only. Top of page 2, I have a table here, just shows you the breakdown of number of transports by DRF to give you a sense of the volume each DRF brings in. And then the following sections are summaries of the different data points. If you want to see more detail, there is an appendix in the back with some tables for you. So let's look at adults first. We have the mode of transportation. About 61% of adults went by law enforcement, 38% by ambulance. And you can see by the chart that this stayed relatively consistent over the 12 months. The next page, we're looking at restraint application. For law enforcement, it's about 86% of all adults transported by law enforcement had restraints applied. For ambulance, there were only 2 instances in the 12 months in which restraints were applied. So you can see there's a very stark contrast between the 2 transport options in terms of restraint usage. And then the following page, we see just a breakdown of the type of restraints used by law enforcement. No one is really dominant over the others. For the child transports, there were only 8 children transported as an IEA in the 12-month period, 5 by ambulance and 3 by law enforcement, and restraint usage was divided directly by the type of transport. Ambulance using none. Then the next 2 pages, since this is now the 4th iteration of the report, gives you some trending data. And to summarize the trends, other than a reduction in the average number of transports per month and the precipitous drop of children because of change in protocol, things are remaining relatively stable across the years in terms of the type of transport and how they're using restraints. So we're seeing that the medical community is pretty consistent in their choices when it comes to IEA transports. And that's the summary for the year 4 report, and open up for questions.
Any questions? Yes, Representative Weber.
Thank you for the report and thank you for taking my question. So I'm delighted by the low number of transport of children, but I want to know how the kids are getting from one place to another. Are they just being taken by their parents in most cases? Is that what happens?
The majority of children's admissions are voluntary. They're not IEA. And
Okay.
so it would be a parent transport.
Okay. In that case, I'm kind of wondering if I've got a disconnect here somewhere because we hear about kids waiting in waiting rooms, in emergency rooms, and they're waiting for a voluntary placement rather than an involuntary placement. Is that what's happening for children waiting in emergency rooms?
Because children are minors, their parents can admit them voluntary by guardian to a facility. So yes, they are waiting in an emergency room for a voluntary by guardian.
I gotcha. Okay, that was the disconnect. Thank you very much.
Seeing no questions, thank you so much. A late addition to the agenda, Representative Leah Cushman has asked if she could make a brief presentation to us. When I got the gist of it, I felt this was in keeping with what this committee does. We receive reports from DHHS, but we also exercise some oversight, and her request seemed germane to me.
Thank you, Chairman Pearson. Thank you, fellow members of the
Could
House.
you hold off until we have the paperwork?
Sure.
We're trying to figure out what is a
Oh, I see. Okay.
stack.
Yeah, they're all just,
I figured it out.
Okay, vertical versus horizontal, I think I know that.
yes.
Wow, see, we're not used to being spoiled like that. Well, sometimes we are, okay.
I know how fun it is to try to do that in the seat while someone's talking, so. Very good. So, good morning. For the record, my name is Leah Cushman. I'm an agent of the people serving in the general court
Could
representing
you
the
be
town of
closer
Ware.
to the microphone, please?
Bring it
Thank
closer to
you.
me. Mr. Chairman, I thank you for getting this matter before the committee without delay. I didn't have as much time to gather stories and names of people who have dealt with the daycares in this issue specifically, but it's not as important as the Constitution and legal principles around why this is an issue. So I'll focus there. So after over the last couple of years, I've received numerous complaints about childcare agencies denying exemptions to vaccination. I had heard many stories and directed people to the statute and said, show this to them and they should honor your exemption. Then I received an email from a woman who sent me a screenshot, and it was of an email from the Child Care Licensing Unit, which is under the Department of Health and Human Services, to a child care agency, which you have there as the first page in the handouts. And I believe what the CCLU agent stated in that email is incorrect, and they're not enforcing the law. And even worse, they're actively colluding with a licensee to deny rights to the people under the law, which is maladministration. And now that they've received notice of this, they continue, it may rise to the level of malice. First, I want to establish what rights are. They're inalienable. You'd have them even if the government didn't exist. And they would only be taken from you by force. Government exists only to protect you from having your rights unduly taken from others by force. I've printed out for you some handouts. If you look at the one with the constitutional articles on it, I believe it's at the end of the first page or top of the second of those. Article 38, a frequent recurrence to the fundamental principles of the Constitution. The people have a right to require of their lawgivers and magistrates an exact and constant observance of them in the formation and execution of the laws. That's why I'm walking us through the Constitution here, because it says that we frequently need to revert back to it and refer to it and look at it. So Part 1, Article 1 says all men are born equally free and independent, therefore all government of right originates from the people, is founded in consent, and instituted for the general good. Article 3 says when men enter into a state of society, they surrender up some of their natural rights to that society in order to ensure the protection of others, and without such an equivalent, the surrender is void. So government exists with the people's consent, and they...
You may ask a point of order always.
Thank you, and thank you for taking my inquiry. It would be very helpful if I understood before you start reading the applicable constitutional principles, if I understand what the problem is, because I've heard the principles many, many times, and I don't know in what context you're addressing them, except that it has something to do with childcare licensing. So if you could tell me what the actual problem that people are encountering is first, and then explain the constitutional principles, it would be really very helpful to me.
Thank you. As I said, a lot of people are being denied enrollment for childcare because they are seeking to use their right to religious exemption for vaccination requirements. So government exists with the people's consent.
Again, before you do this, we want to nail this down. Some child care facilities,
yes,
private businesses, are taking what they believe is their right to refuse to admit a child into their business, into their group of kids, because somebody is not immunized.
Correct.
And your assertion is a private business does not have that right.
Not according to our, well.
Okay, I want to get the point
We'll talk
down
about
before you
private
argue your
business.
point. Is that it?
That's the main gist of it, yes.
Okay. Anyone want to continue to, yes, Representative Merchant.
Let me be clear, we're talking about private business, not a public entity.
Can I finish what I'm trying to, because once I read this to you, you'll understand where I'm
Well,
going.
it depends. If you're going to go through a whole long recitation of the Constitution, no, you may not.
I'm not going through a whole, I'm going to go point by point with the law and how they're violating
Okay,
it.
is everybody clear what the allegation is here that we're trying to deal with?
Yes and no.
I'm
Okay, then
clear
we're not
about the
going-
allegation. I'm not clear why a private business is required to, why a private business is not allowed to govern their own
May I
business
continue?
practices.
May I
Mr. Chair, please, we're talking about private childcare, not public childcare. Are we talking about both?
New Hampshire law says that all child care agencies that are licensed, and the licensing rules also say that they have to honor the exemptions. So public or
Okay,
private.
so the private or public isn't really at issue because they're all licensed, so therefore they're all under a public control. I think we're asserting that. Okay, please continue.
Thank you. So we're here to protect people's rights. And that's what legislators were doing when they created RSA 141C:20-A and C. Those are in that stapled packet there. They imposed a requirement for the protection of rights of the whole, but acknowledged and took due care to protect the inalienable rights of the minority at the same time. That statute says no child shall be enrolled without the required vaccinations, partial vaccination, or exemption. Then it refers to 141C 20C, where exemptions for medical issues or religious beliefs are to be accepted in lieu of vaccination. So they created law that balanced the rights of different people where they may conflict. That's a proper rule. Now the next statute, RSA 170E, talks about licenses being required for certain child care agencies, and they'll be issued in the form and matter as prescribed by the rules. Then you go to the rules further down, and you see HEC 4002.10 D, where it repeats the statute that the agency or licensee shall request documentation on immunizations in accordance with RSA 141C 20A, and then in F, that exemptions to immunization shall be in accordance with RSA 141C 20-C. The legislature put a requirement on schools and daycares that children who are enrolled shall be either vaccinated per statute or provide an exemption. From the email from Melissa Clement, the unit chief for the child care licensing unit, she stated, according to DHHS legal counsel, and you have a copy of that there, the public accommodation statute states it's unlawful for anyone, including a private business, to refuse, withhold, or deny any person accommodations, advantages, facilities, or privileges because of age, sex, race, creed, color, marital status, physical or mental disability, or national origin. She goes on to say vaccination status is not a protected class under this law. That is a deflection, and it's what I like to call a lawyer trick. The controversy at hand is not whether someone has a protection for vaccination status. It's whether they have a protection from discrimination for religious beliefs or disability as is afforded to them in the form of the right to exemptions. It says creed right there in the statute that she referenced. The Constitution of New Hampshire says creed in Part 1, Article 2. That's on your handout. Today, creed has a more narrow meaning of official statement of faith of a religious institution, but in the time of the Constitution's writing, the definition was more broad. Noah Webster's 1828 says it's that which is believed, any system of principles which are believed or professed as a political creed. Creed is protected in our Constitution. Freedom from religious discrimination is also required by the Federal Civil Rights Act of 1964 in places of public accommodation. Disability is also protected. So a medical exemption would fall under that, under the Americans with Disabilities Act. These are protected rights per the Constitution and federal and state law. Mr. Chairman, we hear a lot of talk about the rights of private businesses. If a business is incorporated, it derives its very existence from the legislature. It was created through statute. The legislature created the statutes that enable the creation of incorporated entities such as S-corps, LLCs, 501c3s. Can the legislature grant authority in statute to violate inalienable rights reserved back to the people? No, it doesn't have that authority. The legislature has no authority to violate those rights or delegate a violation of rights to another entity. Maxim of law says the derivative power cannot be greater than the original from which it's derived. Miranda versus Arizona, where rights secured by the Constitution are involved, there can be no rulemaking or legislation which would abrogate them. This is also true of licensees. Licensure is a creation of the legislature. I believe the legislature understood that in creating RSA 141C, that while they could impose requirements for schools and daycares concerning vaccinations, they also had to ensure they were not granting authority for government or its created entities to violate Constitution and federal law. It's about balancing protected rights. So all government agencies and agents are bound to the highest law and expected to act on behalf of the people and defend their rights. So we've got the law creating balance of rights in mind. We have an agency created for common good of the people and entrusted to protect those rights. We have a licensee who agreed to play by the rules for licensure, and if they're incorporated, they agreed to play by those rules in exchange for the sovereignty, to give up some sovereignty in exchange for the corporate shield. So the laws and rules apply to these entities. They don't apply to each child once they're enrolled only. They apply to the agency as a whole and how it conducts its business. So we have the exemption in the law, and I just see a big problem with the agency and the agents and the attorneys, all paid by the people and granted their authority by the people, working together with the child care licensing unit against the constitutional rights of the people. So on your handout, part 1, Article 8, it says all power residing originally in and derived from the people, all magistrates and officers of government are their substitutes and agents and all times accountable to them. Article 14 says every subject of the state is entitled to a certain remedy. And it goes on to say that it should be complete and without denial, and it should be promptly without delay and conformable to the laws. So I'm just asking that we remedy this issue here and now without delay, restore the rights to the people as guaranteed to them in the Constitution and the federal and state laws. I guess we just need the commissioner to give us a plan for that to be implemented, that this practice of telling people that they don't have that right be changed.
Representative Cushman, in the letter that starts, "Good afternoon, Representative Cushman," and is signed by Melissa Clement, towards the end of the big paragraph in the middle, people are not to be denied by age, sex, race, creed. The word creed comes from Latin credo, I believe. It is used in the beginning of the Nicene Creed and the Apostles' Creed. It is a religious statement, broader than, but it at least is that. So therefore, if I'm reading this correctly, one's creed is not a legitimate reason to deny. And then if I go over to 141C20-C in the next handout, a parent or legal guardian, a child shall be exempt from immunization if the parent or legal guardian signs a form because of religious beliefs. Now that means the child can be exempt from having to have a vaccine. I'm not sure where daycare centers fit in under that exemption at the bottom of the page. So I'm arguing both sides of this here. I'm just trying to get stuff into evidence. Representative Weber.
Well, that leads me to my comment, which is we don't take evidence here. I mean, we listen to people, but we are not an adjudicatory body. And the remedy for a violation of the public accommodation statute or any of those other things lies not with us, but with either the Human Rights Commission or the courts.
Respectfully, I disagree. How would that provide prompt and without delay remedy for rights violated? We absolutely work with the departments all the time and advise them on practices that may not be correct. And this seems like the perfectly appropriate body to have that discussion with the department, say, hey, this practice is out of line with the Constitution and our laws, and we would like you to change them.
Representative Weber.
Because what is the problem here is one person has the rights that you're talking about, but if I have a child that I want to send to daycare and I don't want them to be exposed to things that I don't want them to be exposed to, there are two sets of people with two sets of rights, all of which are important. And the balancing act there is either for, certainly the legislature is a part of it, but if you feel that the existing laws are not being enforced correctly, that is why we have a judiciary. It's to balance the rights of various parties, all of whom have rights, as opposed to accepting the rights of one set of people as absolute and the rights of other people as lesser than.
Respectfully, the right to religious freedom is in our Constitution and it's in our laws. So
Yeah,
that
but are we
is
the
a
venue for
delineated
this to be
right.
argued?
But the other right that you mentioned is not a constitutional right.
Fine.
I
but
understand the balance here.
The question is this the venue to solve this problem?
I think if the department is willing to listen and take heed of the notice that they've received that they're out of compliance with the law and they're failing to uphold the law, then yes, I think this is a perfectly fine venue.
I believe it's a venue to listen, and that's why I granted you to come today. I don't think we have the authority to enforce anything and tell them what they have to do. Other members of the committee, how do you read our charge?
I've explained my position. So
Okay.
I will leave it to others.
Representative Murphy?
No, thank you. I understand the concern. And I would agree that if a child or any individual is jeopardized acceptance into a business or childcare or any other organization based on their religion, that's a problem. That should be a problem. And it is a problem in the Constitution, as you pointed out. However, to me, if the parents have chosen not to have a vaccination given to the child because of religious beliefs, that's entirely their prerogative, I would think. So my question is, I would agree, I don't believe that we're the correct body to look at this. It seems to me that this is basically a question for the courts to decide, only because it is in statute that they cannot be discriminated against because of age, sex, creed, et cetera, but not necessarily vaccination. And again, regardless of private versus public, there are so many other competing priorities, including, as Representative Weber said, other people's, concerns and rights. It doesn't seem to me that this is the correct body to make that distinction. It would seem to me like the courts of law should be the ones that handle this.
Representative McDonald?
Thank you, Mr. Chairman. I know this body was created by statute. Does anybody have a copy of the statute handy so that we can know our charge exactly as it's spelled out? Thank you, Representative Weber. She's faster than Representative Merchant with the laptop.
I'm sorry, Mr. Williams isn't here. But
RSA 126A.
813.
I know it's on the calendar, but I don't have a calendar with me.
Is this what you're looking
You don't have a calendar?
Yeah, I mean, I think.
Not a calendar.
at? Is this it?
Street Journal just called me, they want to talk.
126.
May I read number 3?
126A13, yeah.
Good.
it reads, Article 3, Roman 3 says, "The Oversight Committee on Health and Human Services shall provide legislative oversight of the department to support a cost-effective, comprehensive, coordinated system of health and human services that is family-oriented and community-based. The committee shall promote greater efficiencies by consolidating and centralizing reporting requirements and other responsibilities of the department under this section to avoid duplication of efforts, including other non-regulatory boards, commissions, councils, advisory committees, and task forces." That is the legislative charge to the committee.
The representative has made a case, and before we go further, does this group believe that, having heard the charge to this group, we should proceed? And if so, in what manner? That will be the discussion. Representative King.
I first have to declare that I'm an engineer and I don't do well in these areas. But if I can, the way I look at this is that a charge has been made, not that we're here to make the decision on what needs to be executed or determined. It's just that we could be the committee that brings it to the DHHS to be reviewed and a response made. As a matter of fact, I think I heard Representative Cushman make that reference at one point, that she was looking for a plan or maybe a statement from the commissioner on what they have found. And if that's not satisfactory, then she could take it to the next level and then take it to a court of law. That's what I've heard, but then again, I am an engineer.
Other members, Representative Merchant.
Thank you, Mr. Chair. And thank you for taking the question, Representative Cushman. I think there's also another avenue to explore after we get through the process. There's the issue of going to the courts and trying to resolve the conflict between rights. You could also, as a legislator, introduce a bill to clarify it. And maybe that's another avenue for one to consider, because if I read through on the RSA 126A13, I don't see where the committee here has enforcement authority over the department. And that's the part I'm trying to wrestle with. I see a lot of things to do with coordination of care, reports, and that part of it, but not so much the compliance or enforcement within the RSA itself. So I'm kind of reluctant to go down that path because of it. But however, I would also say as a representative, you have the full authority as a member of this legislative body to introduce a bill to provide clarification.
Thank you for that.
Anyone else in the committee? I've shut your mic off. Anyone else in the committee want to give an answer to how we should proceed?
I think I've made it clear, but I just want to say that I don't think this falls into our charge. I think our charge is far more an administrative and reporting thing. We certainly don't have, as far as I know, the ability to tell the commissioner that they're going to do anything. I think that the fact that the representative has brought to us this concern, and it's been heard here, that certainly the department will know that it is a concern, but it has also been brought to them directly. And I don't see what this committee can do, consistent with separation of powers, to compel them to do something that they're not going to do anyway. That would be either changing their mandate by changing the statute, which you have a road towards, or a resort to either the Human Rights Commission or the judiciary as an enforcement action of what's already in place. So those are both, I think, more appropriate forums than this one, because I don't think this is within our charge.
You may turn your mic back on.
Thank you, Mr. Chairman. There's a whole section under RSA 126A:15 that has the duties of the Oversight Committee. And it says it's include but not limited to analyzing, and that goes down to the fourth line, reviewing alternate approaches to programmatic and administrative concerns. And so that's where I felt that this was the appropriate committee. I appreciate at least being able to air the concern here in the public. And I hope to work with the department. I don't want to have to bring legislation. We shouldn't have to bring legislation for what's already in law. And people shouldn't have to go to court to sue for what they already have a legal right to either.
Would you give that reference again? Because I'm slow to write it down. I want to look it up. The charge to this committee where you believe perhaps we could do something about it. What's the number?
126-A:15, Roman 1.
Okay. I propose, yes, you may, please.
I believe that the effective part of that says the committee shall provide legislative oversight of and informational meetings on, this is what you were reading to us, the programs, policies, and rules of the department as brought to its attention by committee members, legislators, department personnel, or others. So far, so good. But the committee shall monitor the efficiency of operation and the quality of services provided. The committee's work may include, but is not limited to, analyzing the efficiency of selected programs, studying the characteristics of target populations, researching trends affecting programs, costs, and participation, and reviewing alternate approaches to programmatic and administrative concerns. The committee may make recommendations to the commissioner and recommendations for legislation, and shall maintain communications with the department and any other departments as necessary. I still don't see that that provides the focus that you're concerned about, as opposed to a more narrowly administrative oversight. So that's just me.
Representative McDonald.
Thank you, Mr. Chairman. I'm new to this committee. I've only been on it this year. And I know that may be true of a number of us, Mr. Chairman, Representative Pearson.
3 years.
I know you've been on it for 3. Have we ever got into any kind of enforcement or anything of that nature in the history of in your experience? Or?
I've only served 2 terms on the committee. I had a hiatus
I've served 3 years and I haven't seen it.
I haven't seen or heard of them, and certainly in my work on the Health and Human Services Committee, the issues that we have referred to the committee when I was not sitting on it have been of a different nature.
Why not this? Since this is going to take some thought, I would propose that I send a memorandum to all of our members. And if you could email me the packets, because I don't have a scanner to turn it into emails, and I will send this to them. And I will say the question I would like us to consider as a committee is this something we should go forward with? In other words, a broad definition of what we can do versus a very narrow definition of it. And if it is our conclusion, we're not going to touch this, we're not going to touch it. And if the majority of people think we should go forward with something, at least maybe just a recommendation, because we have no enforcement, we will work towards that. How does that strike you all? I don't think we can decide it today. Would we decide it by next month, is my question. Representative Merchant.
I would ask the chair to consider reaching out to House Counsel.
Oh, sure.
To understand where we are, because at this point in time, I don't know if we actually have any legal authority in this arena. I think the House Counsel could advise us on where we're treading, so we
Very
don't.
wise, very
That's all.
wise.
Thank you.
Representative McDonald. Sure.
Thank you, Mr. Chairman. I concur. I mean, there's a legitimate concern here, Representative Cushman. There's no question about that. But this committee needs to make sure we're operating within our bounds, and if we don't, then we could actually make it worse if we overstep and undermine our ability to even meet the clear charge that's specified in the statute. So I would concur, and having worked with Attorney Cianci on other issues, most recently a subcommittee that Representative Merchant and I were on, he's very good, he's very thorough, and I think he can give us wise counsel. So.
How's that?
Thank you. That would be great. Yeah, I just, even if it just comes down to a recommendation to the, that our legislative committee was looking at it and finds that it's inappropriate and that they should change their practices. I wasn't saying that you guys, go to the speaker and get a warrant and, subpoena and,
Oh, that crosses my mind on many occasions.
So thank you.
Yeah, and the restraints are put on me when I do. Thank you so much. Is there anybody from the department which wishes to speak to this issue? Yes, come on up. You are here.
Hello, good afternoon. For the record, Melissa St. Cyr, I'm the chief legal officer. Sorry. Hi. For the record, Melissa St. Cyr, I'm the chief legal officer for the department. I oversee our legal services, but I also oversee our Bureau of Licensing and Certification, which includes childcare licensing. I agree with Representative Cushman that there may be a valid reason. I can't speak to whether or not these individuals have a right or a claim, obviously, but our childcare licensing rules, they oversee the quality of services that are provided by the childcare agency. They don't oversee the kind of how they accept children into their program. It really only has to do with the quality of services that are provided once they're actually there and in the program. And so we do require them to have on record if public health requires, if our 141C statute requires that immunizations be on record, that we require the child care agency to hold those in their record. And if there's an exemption, they also have to have that exemption in their record for the child that's in their care. But we don't dictate who they can and cannot take in, because it really only has to do with 171E, which is our statute that talks about quality of services of the children in their charge. That being said, there is a statute around discrimination for certain aspects under RSA 354A, which is what was mentioned already. If there is a discrimination, any kind of discrimination that has been alleged at a child care institution, we would contact the Department of Justice for them to handle that situation. So it's not something that we would deal with from a licensing perspective, because like I said, that has to do with the quality of services. So it's really the Department of Justice who we would contact and just say there's been a claim that there's discrimination against this this family for the way that they're intaking children, and then we would leave it in their hands to investigate and make a determination, or the individual themselves, the parent themselves, can also seek their own counsel. So that's essentially how we handle that.
So even if we think about it for a month and come back and say, hey, let's send a memo to DHHS, it isn't DHHS that would
Correct.
receive it.
It's not something that we deal with.
Cancel that meeting. The complaint would come to you folks.
Yes, if
and
we
then
got a complaint that there was a discrimination, that there was a violation of that statute, that's not we only enforce RSA 170E. That's all we have the authority to enforce under childcare licensing. So other statutes, including the public health statute, we would have to refer to public health. If it were a 354A discrimination statute, we would have to refer to the Department of Justice, or as I said, they would have to seek their own counsel.
Could the aggrieved citizen go to DOJ directly?
Absolutely.
Okay.
Absolutely. Yep.
Mr. Chairman,
Yes.
just to clarify, which meeting did you want to cancel?
Not next month. The scanning all of these documents and sending everybody an email and coming to the conclusion whether we want to make a remonstrance to the commissioner. And that's off the table now, because it doesn't matter even if we did. Yes, Representative Merchant.
Yes, I think it's definitely off the table, but if it's okay with the chair, I still like to have the chair reach out to House Counsel to understand what our role and what our guardrails are, because I think if this comes to us before, again, or anything like it, we should be able to respond to it accordingly, saying this is not within our scope of authority.
And
Just get it cleared up and get it done with.
Because other things like this will come up. So let's be ready. Yeah.
Mr. Chairman?
Good, yes.
And for that purpose, would it be appropriate for Representative Cushman to still send that so that House Legal Counsel could look at that paperwork, or?
You have an extra copy when I run up to see legal counsel?
You know where he is, right?
What's that?
You know where he is, right?
Yeah, fourth floor. Thank you. Anything else you have for us?
That's all I have. Thank you so much.
You have cut the Gordian knot. Thank you.
Thank you.
Take care.
Yes, thank you. Okay, there we are. That's the agenda, and I think we gave a good airing to that subject, and we have a way forward. Representative Cushman? No, happy? Well, I mean, not, crazy happy, but thank you. That's what I wanted. Okay, with that, next month, December 15th, going away party for Paula Linehan. So she's already gone away and practicing going away. And that will be Friday, December 15th at 1 p.m. Thank you. We are adjourned.